Before we dive right into discussing diverticulitis, I would love for you to watch the video labeled Diverticular Disease that is in the GI module. It does a fantastic job illustrating what is exactly the problem inside diverticulitis, and you can sort of get a really good visual of what I'm talking about, what I'm describing these next few slides. So stop right here, watch that video, then come right back. If you've already watched the video, then let's move on forward. How did you like that video? I know, right? Okay, so let's talk a little bit more about diverticulitis. Diverticulitis begins with the intestinal wall that just gets a little weak, and then these little outpooches occur. I will mention that a weak intestinal wall is part of the normal aging process, and so we are going to see lots of cases of diverticulosis in our older population. However, diverticulitis is when we have infection and inflammation in one of those little diverticula. We see it in our younger population, and it's usually related, or if we do see it in our younger population, it's usually related to a diet low in fiber. Sounds like the all-American diet right there. Now, the problem in diverticulitis is that food, seeds, stool, and bad bacteria can get stuck in the diverticula, and with this occurring, it's actually going to decrease blood flow to the intestine, and we are going to be prone to develop an abscess and rupture. Ugh, worst case scenario. That's not good. What else would I like to say? Just to follow up on the notes, it can occur at any gender. However, men will develop diverticulitis more than women, and it can occur in any race. However, there is a prevalence among African Americans. Intermittent left lower quadrant pain that gets progressively worse and steady is going to be their main complaint. We want to be looking for abdominal distension and tenderness over the involved area. And you can probably guess if peritonitis is present, they will have profound guarding and a positive Blumberg sign, as well as a rigid or board-like abdomen. They will have a fever. Now, I will say if the patient has a fever greater than 101, if they have pain that lasts greater than 3 days and GI bleeding, they need to be hospitalized. Otherwise, diverticulitis can be managed at home, maybe just through PO, antibiotics, and a clear liquid diet. The blank here for altered mental status, this is a lot of times the first sign in an older adult. Over here, stool test will show occult blood. Their white blood cell count will be high. Their H&H will be low from some of the bleeding that they have in their stool. X-rays and CTs are going to be demonstrating the thickened bowel, or they may even show free air in the abdomen, which means they have a perforated diverticulum, and this is considered bad. The person needs to possibly have surgery, or if it's small, they can just do bowel rest and it will self-seal. If the patient is in the acute phase of diverticulitis, usually an ultrasound is done to make a diagnosis. Right here. A sigmoidoscopy can be done with an awake patient because the scope only goes up maybe 6 or 7 inches, but not so much with a colonoscopy. That one a person has to go to sleep for. We do these to take a better look at the problem and to rule out a tumor, which is always a possibility because a tumor can mimic diverticulitis symptoms. Okay. Last slide. IV opioids may be warranted as the pain can get quite severe. Metronidazole or Flagyl is one of the most well-known gut drugs or say gut antibiotics, a patient could be placed on to kill the abdominal infection. So I see that one a lot, actually. Absolutely no laxatives or enemas for this patient, as you could possibly perforate the already compromised bowel. You may possibly put them on IV fluids. We're looking at isotonic fluids. NG tube is likely to be given or inserted into a patient in the acute phase, like say the first 3 to 5 days, but the patient should definitely be receiving IV fluids if they are NPO and have an NG tube, because they are super nauseated and vomiting or even distended. When they can't tolerate food, they need to be on when they can tolerate food, patients need to be on a low fiber diet, also known as a low residue diet. When they go home and are better, they need to be on a high residue diet or a high fiber diet. This is so important that they don't have another episode due to improper diets. I mean, goodness, they can take Metamucil if they don't like food that has fiber. In fact, sometimes that's a prescribed thing a person will need to take. They also need to remember to increase their fluid intake if one is to up their fiber intake. It really gets everything moving. It's not good just to take fiber alone. It has to be fiber and fluids. Now, food that has fiber in it is like green leafy vegetables, oranges, apples with the peel on it, whole grains, even some cereals. Regardless of what phase they are in, they always need to avoid anything with seeds like strawberries, cucumbers, tomatoes, figs, corn, nuts. These are bad, as the seeds can get stuck in the remaining diverticulum, and we'll go through the cycle all over again. Let's see, if somebody has active diverticulitis, do you think they should have low or high fiber? Answer is low. When they get discharged and they're past the acute phase, do you think they should have low or high fiber? High. Very good. Now, let's just say somebody had to have surgery. And if someone has a colostomy, it can either be permanently placed or temporarily placed. I actually had this one patient. He came in so many different times within the year because he would not change his diet. And finally, his sigmoid and his cecum were so full of holes that the only thing left to do was a bowel resuction, because he continued to get peritonitis and almost died a few times, actually. Anyway, they had to place a permanent colonoscopy, and they sewed up his anus. Now, food for thought. What if you had a nauseated patient who couldn't swallow pills and they didn't have any IV, but they need Tylenol, and you have an order for a suppository Tylenol, such as in this patient in my example? Would you give it how? Question? You would actually install, like it's a car part, you would insert the suppository into the person's stoma. Yep, right into the stoma. Now, if they have an actual anal canal and they're not fresh out of surgery, they can actually have the suppository placed, like a normal patient, because even though it's sewed off, there's blood vessels that will soak up the medication and put it right into the bloodstream where you need it. However, the person who has had bowel surgery with an ostomy placement and say was just left with a rectum and an anus, they can actually pass they can actually pass mucus, just like a BM. Believe it or not. This is not testing material. I just wanted you to kind of know this for real life, if you ever run into this situation. Okay, I believe this is it for the bowel section. I hope you have a great afternoon.